Western blots looking at mitochondrial proteins, porine for an example, or complex 2 proteins. You see a lot more of that in the chronic lesion. And this is a Western blot of a protein called synaptojanin. And what's interesting about synaptojanin is it's actually an axon-specific mitochondrial docking protein. So it won't be there if the mitochondria are just simply stuck and they can't move. And it's there because they've been actively docked in that place. So if you do confocal microscopy, you see in these chronically demyelinated axons, the mitochondria are actually expressing the docking protein quite a lot. And again, this points out towards an adaptive or a homeostatic process. So what happens with remyelination? If you see that demyelinating response, does it completely reverse? And the answer is it doesn't. So these are MS lesions, and you see a myelinated axon here with the mitochondria pointed by the arrowheads. You see a demyelinated axons really stuffed with mitochondria. Not all the axons really show this abundance of mitochondria. And then you see a remyelinated axons where the mitochondria are much more numerous, but in terms of size, they seem to have gone back towards the myelinated levels. When we tested this in an animal model, we injected ethidium bromide into the CCP, where we could control the time points, complete demyelination, early remyelination, and late remyelination. And you see the same thing. You see an increasing mitochondrial content and activity with demyelination, tends to go down with remyelination, but it never really normalizes to the myelinated level. And you can confirm this with EM. And this is work from Nobu, from Bruce Strapp's lab, in vitro work with DRGs and Schwann cells. So it's a peripheral kind of nervous system model, but when you demyelinate and look at remyelination, you see exactly what I've shown you in MS and also with following experimental demyelination in vivo. So this seems to be a fairly kind of a generic process to demyelination. And Nobu also looked at mitochondrial movement, and this is very much an underexplored area. And what you see is you see much more stationary sites. So when you demyelinate the axon, and I showed you a lot more mitochondria in it, most of those seems to be stationary, and that kind of supports the synaptojanin evidence that when I showed you that these mitochondria may be docked. So that's nice data to support the neuropath observations. Nobu also saw some movement changes. So there were more motile mitochondria. And remyelination seems to reduce the size of the stationary sites and increase the mobility of the mitochondria. And now, one of the important things we haven't looked at with these models so far is what are the implications of this type of a transport or fission fusion phenomenon for the distal part of the axon. So in a cortical spinal tract, for an example, when you have multiple foci of demyelination, how does the proximal demyelinating lesion influence the distal one? And I think this kind of transport abnormalities really compartmentalizes the axons, particularly the long axons, into different segments. So you have the proximal segment, distal segment, and the mitochondrial damage that happens in the distal segment may be actually compartmentalized and accumulating over time, and these mitochondria just cannot get back to the cell body and then cause dysfunction. So, I mean, this is a hypothesis, we're looking at that, and the preliminary data is actually pretty encouraging. So if you look at the distal demyelinated lesion, the mitochondrial response to demyelination is not as prominent as in the proximal one. Okay, so this is just to summarize what we think goes on with the axonal mitochondrial changes to a disturbance in myelin. So here you see the myelinated axon, nodes of Remyelination, and I mentioned about the paranodes and the juxtaparanodes and the internodes. And there's obviously differences in the ion channels and the ion pumps and so on in the different compartments. And this is again Nobu's work in myelinated axons, where you can see a distribution of mitochondria, and 90% of the mitochondria are actually in the internodes. So despite the nodes of Remyelination being considered as the most energy demanding sites because of the sodium channels, most of the mitochondria in the central nervous system axons are actually localized in the internodal region. And when you demyelinate, you have a spread of the sodium channels and potassium channels and sodium potassium ATPase. Mitochondria gets longer, so presumably they've undergone fusion. There's more mitochondria being transported into that demyelinated segment, and they're expressing synaptojanin. And then here it's remyelinated axon, where the size has gone down, but you certainly see more mitochondria in the remyelinated axon than in the myelinated axon, although we're not quite sure about the compartmentalization of mitochondria in the remyelinated axon. Presumably it's the same as in the myelinated axon. And then these are the myelin models. So we've also looked at Shivera mice, for example, who lack MEP. So these mice don't have compact myelin, and then the axons are dysmyelinated. And the other point about these animals is that they don't really mount much of an inflammatory response, but you still see the same axonal mitochondrial response that we've seen in the demyelinated axon. So disruption of the paranodes and juxtanodes and the redistribution of the ion channels seems to be pretty critical in terms of the redistribution of mitochondria. And presumably, in a temporal and a spatial sense, if these are disjointed, for example, if the ion channels moves following disruption of the nodes and the paranodes to a different section, and the mitochondria can't get that quick enough and supply the energy, that might be catastrophic. So on the right-hand side are the different scenarios where the axon could undergo degeneration. So the right top diagram here shows dysfunctional mitochondria which have been fragmented. So this is Martin Kirstensteiner's work, for example, showing how myelinated axons can undergo focal axonal degeneration. And this is a scenario where both Bruce Trapp and we have described how, and Rick's work from looking at MRI tissue from lesions lacking sodium potassium ATPase. So this can highlight dysfunction before degeneration in MS. We're very familiar with dysfunction in the relapsing and remitting stages of MS, but even in the progressive stage, it looks like there's a bunch of axons just sitting there and not working properly. They can't maintain the membrane potential if they don't have the ATPase, sodium potassium ATPase, and if they don't have intact mitochondria, they won't be able to generate the energy that's required to keep the membrane potential. And then presumably it reaches a critical threshold and it kind of switches off all the calcium pumping and so on, misbalances calcium undergoing axonal degeneration. So from a therapeutic sense, if you had to put your money and say, well, which way you want to modulate axonal mitochondria, one of the very good scenarios would be to remyelinate the demyelinated axons. Then you can restore the energy efficiency and so on, although not perfectly. But if you were to preserve chronically demyelinated axons, is this response a good thing or it's a bad thing? My guess would be that this is actually a good thing. It's an adaptive homeostatic mechanism. If you look at the optic nerve, for example, lamina cribrosa, which has the unmyelinated fibers, then you see the same kind of response. You see more mitochondria, larger mitochondria, and more mitochondrial activity in that segment. Of course, this is in controls, and that's not pathological. So if you were to kind of preserve chronically demyelinated axons, I would argue what the line that we should take is to really preserve this mitochondrial response. But there might be a price to pay for that, particularly for the long tracks when there's a distal demyelinated lesion and the synapses are about 1,000 miles away if you're about 3 meters wide. Okay, so the take-home message here really is both energy supply in the cell body, in the neurons, and the energy demand is affected in MS in the wrong way. So the overall energy imbalance is due to a decrease in supply and an increase in demand. So I'd like to finish that and thank people in Newcastle and Cleveland Clinic. One of the very sort of common things about Cleveland and Newcastle is actually they've got very interesting bridges. And I think there's a lot more bridges to be made to actually link in the role of energy deficiency and neurodegeneration. Okay, thank you very much.
Discussion now.
One of the things we've noticed in the autopsies is that in about 20% of the cases, they're late stage, very disabled patients who then die and donate the brain. About 20% of them, we don't have any more demyelinated lesions, even though they had very typical MS, very typical MRI features. They die late stage of MS, and you cut up the brain and there's no demyelinated lesions. And yet the patient had been gradually getting worse. So my question is, from what you said, it seems to me that the neurodegeneration may not require an active pathologic process. Is it possible that in the later stages of MS we have a post-polio type syndrome where there's just an overuse, a deficiency in the number of axons or neurons, and a mismatch of energy demand and supply? So if that's, and the scenario I'm getting at is it possible that MS is gone and all we're dealing with is an aging process superimposed on pre-existing MS?
Absolutely. I think that's certainly possible. I mean, in such a patient without demyelination, there could be a considerable extent of dysfunction. I'm not sure if you can hear, which you wouldn't necessarily see in pathology. Right? I mean, you could have myelinated axons where the energy supply is all messed up through this process, for example. Cortical lesions or the diffuse inflammation could accelerate this aging process and cause those to be dysfunctional. And also it might contribute to atrophy that way too. So I guess then the question there is, how much of a bigger deal is this? How many cells are being affected? And it depends where you look. So if you look at the cortex, it's about 1 in 300. So that might not actually give you sufficient dysfunction or degeneration. But if you look at certain other regions, which we actively look at with Bruce, we can discuss later on, and these regions actually, over 30% of the neurons show this change. So there, I would feel more comfortable that there is a dysfunction or a significant component through this accelerated aging process. So it may not affect, all the regions, but it might affect the corticospinal tracts and certain other key regions much more than others. So it's possible.
Are there therapeutics we're using currently, I'm thinking of 4-AP for instance, that could potentially be detrimental because they're increasing demand on a sick axon?
For example, that scenario, or also if you ask patients to exercise and, try and get the conduction going in these axons, is it a bad thing? I mean, I think exercise is a good thing, and it would be hard to push these axons beyond what they're capable of, I think, without messing around with the situation. So they presumably adapt it, to a comfortable situation. And if you maybe all of a sudden start to introduce lots of sodium channels or start to stimulate, and there isn't the energy supply, that might be catastrophic. For example, I think Ken Smith's work about in animal models, if you stimulate after exposure to nitric oxide, high concentrations, then you see axonal degeneration. So maybe actually the situation the patients are at might be okay, but if you start to tweak with things, maybe we have to be careful that we do the right thing. And really, it's a triad, if you like, the electrogenic machinery, myelin, and the energy supply is a very closely linked triad that we have to consider from a therapeutic perspective.
Amit, can I problems emerge? Then of course it's easy to think about a condition like MS. But what do you do in children, for example, who already have some developmental disability or developmental delay? They might have other lesions due to early brain injury. So how do you diagnose in those situations? Do you think about it at all?
Yeah, so it's an interesting question. I mean, one aspect is that the differential is broader in the younger kids, who are also the less frequent presenters. So the numbers get pretty small. Even in our cohort of 300 and some, which perhaps on one hand is the largest out there, it still is rather small numbers overall. We have seen MS in the youngest individual who turned out to have MS had an initial episode at the age of 18 months. So of course at the time no one was thinking of MS, although this person was captured in the study and followed prospectively, and no other diagnosis emerged, and then the child had in fact myelitis and then some other brainstem syndrome and so on, and clearly has multiple sclerosis. We haven't really seen dual diagnoses in the sense that a child comes in with an inflammatory presentation, and that's how we capture them, in whom we find another disease that turns out to be in addition to MS. Maybe it's just a question of time.
I had a question. Another question question for Amit. If, based on your experience so far, it would seem that if you combine the clinical features of the MRI, the vitamin D, the EB virus, you should be able to fairly accurately predict at the first symptom whether it'll be MS or monophasic. Is that the case? And how well can you predict?
Yeah, so we attempted to do this. We thought when we got to this paper that I was mentioning just got in the Lancet Neurology recently, that we would be able to come up with a multi-parametric approach of having superb sensitivity and specificity. The single best predictor by far was still MRI. And although each of the other parameters was independently associated with risk, adding them to the MRI didn't help. Now, that may mean that we're dealing with things that are at exactly the same pathophysiological or pathobiological cascade, so that you're capturing true and related. But the other, which I think is a challenge, is that when we approached this initially, we thought we're capturing the overall ADS population, and so we can really talk about things that may be associated with the person developing versus not developing multiple sclerosis. But in fact, when children present with an imaging profile that is high likelihood MS and predictive of MS, it's not that they're going to get MS, it's that they have MS. And so probably even in the children who present with the first episode clinically and turn out to have MS, they have had other disease activity prior. And so, for instance, the application of the revised McDonald criteria and looking at the degree of atrophy that's already present there in black holes and so on, is consistent with the notion that most of the kids with ADS, who we subsequently diagnosed with MS clinically or by MRI, in fact, when they presented, already had MS. And the others just don't and won't, which challenges a little bit the comparator there. And I think that that's probably why the MRI is such a great predictor of the MS diagnosis, because it already tells us that MS is happening. And the question is, how many of those who have classical MRI features of MS, including evidence of a history to that disease, in fact won't have MS? And I think that that's going to be minusculely small.
So the other, one last thing, and then I'll stop. But this is for both Don and me. We're hearing that in pediatrics, the pyramidal system recovers very well. Kids run around and motor-wise they do fine. In later stage MS, with aging, the pyramidal system is preferentially involved. So why is this? Can you tie these two observations together? Is this the length of the neuron and the energy metabolism, which gets worse with age? Why do we see this discrepancy?
I think it's a great question. The reason for which the recovery is better earlier in terms of the pediatric onset context is something that we're grappling with, and I'm very interested from a neurobiological standpoint as to whether this represents better recovery. Now, the rate with which this gets better is rather quick. So how likely is this to be regeneration? Unlikely. Is it remyelination, which in fact can happen surprisingly quickly, possibly? Or is it just a different inflammatory profile that resolves more quickly with more resolution and more complete resolution of edema? So whether this is an immune aspect or a neurobiological aspect, I think is too early to know. But it certainly would make sense that later in life, if the accumulating problem that relates to the energy supply and demand mismatch is going to manifest, it will likely manifest in those pathways that are the longest and working the hardest.
I agree with that, Rick. I mean, certainly remyelination would be an important issue. If you get failure of remyelination as you get older, I mean, I know that's not the case in every case. That could certainly contribute to dysfunction and increasing demand. But I guess also certain pathways are probably more susceptible. So if you have longer tracks that are more likely to get damaged, the mitochondria that could be damaged through inflammation, that comes back to the cell body, or the actual rate of metabolism is much greater. So corticoplexus epithelium is actually metabolically highly active, and that's where you see the same thing with ciliary epithelium, the age-related changes. And it's interesting, actually, we've looked at the paraspinal muscles in MS cases, which are different from the other skeletal muscles. And you see an accelerated aging process in the paraspinal muscles. So I think, the highly metabolically active pathways are much more susceptible to acquiring these kind of accelerate aging phenomenon, which is not going to be the only reason why progression of your old people might be, but I think it contributes to the dysfunctional level, also the susceptibility-wise to additional factors.
I just want to disturbance. There's a remyelination in some cases, whatever it is. Does it mean that the remyelinating mechanism is put out completely and there is no remyelination? Whatever cell is responsible for remyelination. Do I take it that way?
Yeah, sure. I mean, it's a very interesting question, and we're trying to answer that in certain models. So you can create this supply energy problem. I mean, one of the problems about the existing models of MS is it doesn't actually model the global perspective of decreasing supply in the cell body and increasing demand in the axon. So we are trying to create some models where you can get both. And we look at that, and one of the things we look at is the remyelination capacity. I'm slightly discouraged by what we might find, because there are in vitro studies, for example, where the axons have been fixed in paraformaldehyde and then exposed to Schwann cells, and it shows remyelination. So Schwann cells somehow seem to remyelinate these fixed axons. So how important they are? I mean, I think the axonal signaling is very important for remyelination. So that kind of thing makes you slightly disheartened, but I suspect an energy failure in an axon would interfere with ATP production, and ATP is said to be a signal for oligodendrocyte progenitor cells, for example. So it's possible if you have an axon which is energy deficient, that in itself might actually impair remyelination.
There may be another layer to this, in that we know that developmentally the neuron probably solicits responses from a variety of different glial cells, not just the oligodendrocytes, certainly the astrocytes as well. And while for the oligodendrocyte precursor cells it's relevant for myelination, for the astrocytes there are aspects that relate to the quality and function of synaptic arborization and so on. And of course these are glial cells that become increasingly involved and increasingly damaged with time. And perhaps this feeds also back to Rick's question that with time the disease is causing additional problems that strip away or create even greater uncoupling between the neural and the glial elements, and it becomes a self-perpetuating process, and that as time goes on there is less to protect and enable and more injury and less ability to meet the demands.
If there are no more questions, I thank the speakers for their thought-provoking lectures, the audience for their active participation, and on behalf of Dr. Meena and myself, I thank the organizers for this opportunity. Thank you.
Now we request Dr. Gauri to put the shawl to Dr. Mahat. Gauri to give a memento to Dr. Mani. Chairperson is going to be Dr. M.M. Mendirata from New Delhi, and Dr. Deepak Arjun Das will be the moderator.
Friends, good afternoon. Clinico-pathological case is always a high point of any meeting or congress or conference. And if we can reach the diagnosis pre-mortem, it's creditable and reflects the clinical skills of the physician or caring doctor. So here we have Dr. Deepak Arjundas, who is an astute clinician. He is a very close friend. He is DM Neurology and he is FRSH and FAMS. He has done DIP Neuro from London. He had been attached to Institute of Neurological Disease, Queen's Care, London and Mayo Clinic. And he has special field. You have to see his stroke unit. Whenever we meet, often it is discussed that the type of work he does and the hard work he does. Work everybody does, but he does a lot of hard work. He has stroke team at Mercury Nursing Home. He is founder member of Pacific Stroke Society and member of International Stroke Society. He has a number of active ongoing research projects in prevention, treatment and stroke rehabilitation. You will see when he comes, he has kept the case very close to his heart. As a discussant, I am supposed to know beforehand, and I should have also prepared some PowerPoint slides. But he said no, he will throw it open to the house and also to the chair to guess. We met 5 minutes back and he said it's another case of failure. I said that's the key to success, because failures lead to success. If we never have a puncture or a flat tire on the road, we'll not know how to fix the wheel. So that's his story, and he's going to put an interesting case here and hope we'll have very good discussion. Deepak, please.
Good evening, everybody. I'm basically a stroke neurologist, but I have a lot of interest in MS because we started the MS Society in Chennai, and with that, the interest in MS picked up. We have a lot more strokes and demyelinating disease. Then came the association with Shankar Nethralaya, where we have a tremendous load of demyelination. Many of the demyelination turn out to be multiple sclerosis, and many demyelinations are yet to be identified. There's nothing close to my heart. I always like to present a case where I have failed in giving any improvement to the patient. I very rarely present a patient which has done well, because it's nice to know where we stand most of the time. When there to complain about somebody, and this is what I found he was looking at. He said great minds discuss ideas, average minds discuss events, and small minds discuss people. I took back my complaint letter and came back because I didn't want to complain about anyone. Then he left. Good. Evidence of absence. I have many guides, and I learn every day. Every night when I drive back at 12, I laugh at myself to see how stupid I've been. This is one of my patients which have not done well, and all of us know we are on a neuroinflammation conference. I won't bring a stroke patient. I will bring an MS patient, but I'd like to share with you how difficult it can be. One, I want to a patient in our country. This is not like anywhere abroad where you go to a fixed clinic. A patient in India can travel 3.5 hours and have several consultations at his wish and can change treatment overnight, as you will see. It's an interesting concept because most of the patients that we get are from out of town with multiple sclerosis, and they go through a chain of my team. For multiple sclerosis, I have a fixed team wherever the patient comes from. One, we have Dr. Veena, who does the imaging, who reads all the imaging even if she doesn't do it. We have a neuro-ophthalmologist, Dr. Ambika, she's not in town, she's supposed to be here, and myself. Then we have other people who come to the team and help us, especially the MS Society. This is a young 16-year-old girl in the 10th grade when she saw me in 97, and she was doing good athletics in school during her evening time. She would dance, she was a Kathak dancer, and she said that, sometimes I feel tired after my training, I get weak in my legs, I rest and I get well. I know that's quite common if you over-exercise, and it's quite normal. Then, sometime back, she said, her mother came and said, she stopped her dancing. She says, no, because I have weakness in the legs, next day I find it difficult to do my athletics and dancing, so I grew up dancing because I like athletics. She came the first 3 ranks in class when she met me, and there was no fatigue, no history of fatigue other than accepting when she went on these strenuous tasks involving her legs. Sometime in the 2nd week of March, she woke up one morning with an abrupt weakness in the left leg. It was a weekend. Getting an appointment with a neurologist was difficult. She went to a family doctor the same day. He examined her and he just said, there's nothing wrong with you. You had excessive training a day before and nothing would happen. Just go home, eat fruits, rest, and you'll be well. So that was it. In about few days, she recovered. What the doctor thought was fully, but still she said that she had only partially recovered. But on examination, she was quite normal, as per the notes given by her. She went back to school. She was as usual, and she went back to athletics partially, not fully. In April, the temperature in Delhi becomes a little more warm. This time, after a bout of practice, at night sleep, next day morning, she noticed that she needed help to get out of bed. And she noticed she had weakness in both the lower limbs. Her mother came in to help her to walk and then found that she was quite imbalanced. She was swaying to other sides. While being taken out to the room, she noticed that she could see double. The double vision was on all sides. She had to be physically helped with one support to walk to the toilet for activities, for her to look after herself, for an ADL. That day evening, she came down to see a neurologist in the evening. He examined her and he found that she had nystagmus on right and left lateral gaze. She had incoordination both hands, both legs. She had truncal ataxia. She had wrist reflexes and a plantar extensor. We're not very sure of what was the sensory signs at that point in time. Do you know autonomic signs? This was around the 20th. By the time they organized an MRI, the MRI was done, and he also asked for a CSF. The patient was admitted. CSF routine was done. The neurophysiological examination was done. And those days we didn't have facility for NMO here. We drew the blood and sent it off for the NMO test, the appropriate antibodies. All were done within the first week of admission. This patient was admitted and started on methamphetamine for 5 days and then given oral steroids for the next 15 days. You have the MRI for this? We have the we have the reports for all the MRIs done, about 20 MRIs, and we have the films for 4 years.
I think as clinicians first we should think that what was the likely possibility.
And stop now. Let us go to MRI and then while you're setting up. So the neurologist who works with me in coordination in Delhi called me up and thought that that the patient needed admission and was thinking of a demyelinating illness. That's what the patient thought. But you want to ask anybody?
I think it would be worthwhile asking from we have such international experts here.
Good.
Have in mind.
For, I think what Deepak has enumerated just in 3 lines, I'll say, when was the first episode? I'll clarify something first.
March was the
March.
next like main week.
March 2007. Okay. The first episode was March 2007, and which recovered spontaneously. We don't know the duration of that episode. That was
Just about a day or two. That's all. Patient was
more than 24 hours.
Yes.
Okay. So first episode was more than 24 hours and weakness in her legs with spontaneous recovery. Then she had abrupt weakness in left lower limb, and then in April 2007 she had weakness both lower limbs. 20th April she had additional symptoms in the form of double vision, bilateral ataxia, bilateral upper motor neuron symptoms and signs, what my friend has mentioned, and plantar bilateral upper. So that's in nutshell the symptom complex of this patient and signs. So now we can start debate on likely possibility. And then certainly either one is 3D MRI correlated retrospectively, or first make a clinical diagnosis and then go to the MRIs and correlate. Professor Ryu. Yeah. Mike.
The differential might be between a inflammatory demyelinating condition and a vascular condition, because there's episodes and they get better. It's not common for MS episodes to occur abruptly, as I think you said first did, which does increase the possibility of a vascular problem. The other thought that I have is that whenever the syndrome can be explained by disease in one location, so that if it can be explained by a single site lesion, you have to worry about the single site. So the issue in her case could be that it's explainable on the basis of a brainstem lesion. So beyond that, I think we need testing.
Absolutely. As I think the saying goes, that acute onset we have limited possibility or sudden onset. One is vascular, second is demyelination, third is trauma. So here there is no trauma. Demyelination, as he rightly said, looks a possibility but less than the vasculitis. Then comes the site. Is it spinal cord and the brain, or is it only the brain, by which we can place a lesion in the brainstem, but it's causing weakness only in the leg, and then both the legs. So certainly in certain, because the fibers are very transverse in brainstem, particularly pons, and spread out. So maybe it's a patchy involvement, and also the double vision, which indicates cranial nerve. It becomes intraaxial lesion because there is a associated pyramidal and cerebellar. So I think I will agree with him. There are two possible. One is one site like brainstem, and there's one disease like, suppose there is something sitting near the brainstem which is causing ischemic events. One that, and second is demyelination, again one site, or intracranial and spinal lesion. Professor Rudik, any other thoughts? You think it's only brainstem, or can be even spinal cord and brainstem?
Well, I think from the sound of it, it could be multicentric.
Yeah.
But it not necessarily. It could be a single. So I always get a little concerned when it could be one site in the nervous system, because there you have to be concerned about a vascular malformation or a tumor.
That's right. No emotional changes, no behavior.
Not on this examination, not in 2007.
No history-wise.
History-wise also, only what was worrying me was the history that we got was you were always tired after exercise, weakness in the leg after exercise. Though the good physician said that she had recovered fully, but this girl kept on saying, I'm not as strong as I am in my legs. Though clinically she was quite all right.
No,
So
mild to moderate exercise or vigorous exercise?
No, athletics is quite vigorous exercise.
Oh.
No bladder symptoms?
Sorry?
Bladder.
Not at this point of time, not on that time.
Yeah, Natarajan. Yeah,
I
please.
just wanted to raise the point that Deepak raised when Professor Ruby discussed it. This question is that he started off saying that started at 16 years of age, wherein she complained that she was not able to carry out activities which she was able to do earlier. Initially it was fatigue, and it went on to the stage wherein she had to give up her dancing. So there was something which was going on, and if that were to be taken into consideration, how the differential diagnosis differed, would it favor more of a demyelinative problem, or starting at 16 years of age, sort of hanging around for 10 years, then manifesting with a definite sign? Certainly, yes, at the present time when it manifested, it was a brainstem involvement. But if we take that into consideration, between, of course, arteriovenous malformation is certainly still possible, but between the two, there be a choice, first preference for the second preference. Because basically, I think these are the two differential diagnoses we have.
I always vote for MS. I think you have to keep an open mind.
Because in the institute, when we have patients like this, when we were training, when they had weakness, we always thought of a muscle problem, a muscle disease, or a spinal muscle, a lower motor disease. But we did not think as of demyelination in the wildest of our dreams. Because whenever they had a fever, then the muscle would get worse, and then they would present with a muscle disease like this. But only after the
How old is she now?
so 16, so
Plus
4,
5.
21 now.
Not 10 years, Natarajan. 5 years total.
No, I thought when she presented in 97, she was 16-year-old.
Correct.
Then 16 plus 15, she's 31 years old now.
Well, 97,
2007.
2007.
2007. I go to her.
So 10 years.
No, 2007 was the first symptom.
Natarajan, initially by chance he spoke 97, but it is 2007.
I'm sorry.
Ah.
I thought it was 97.
No,
Even I wrote
2007.
97, I also wrote.
No, 2007.
2007.
Sorry.
So, initially, personally, I thought I was dealing with a muscle problem because it was a child. I did not expect that bad luck would come on me and get a demyelinating with what they want to see on MRI. I thought it could be a muscle disease as the first possibility, some sort of a motor neuron disease affecting the anterior horn cells, and then I thought it could be something which we had to sit and look for. We have patients with mitochondrial disease which present like this. On exertion, they get fatigue. With rest, they get better. And I have a lot of patients like that now, which have been proved by electron microscopy and by studies. So with this, the doctor aims for some imaging, and she'll have the image. What did you see?
Good evening, everyone, and thank you, Dr. Deepak and Dr. ESK. It's a real pleasure to be amongst renowned neurophysicians. I just take you all through, we had about 4 MRIs done in 2007, 9, 11, and 12. So here is the first MRI done in 2007, that is when she presented. This is an actual flare sequence. I don't know if it's clear. Okay, so this is an actual flare sequence starting from the foramen magnum and take you above to the supratentorial brain parenchyma. Now, flare is not a sequence. Generally, brainstem plaques are not well seen. So we just go through the supratentorial brain parenchyma. And here you see the typical multiple periventricular ovoid round lesions. Okay. And this is the SAG T2 sequence, which will show you the brainstem plaques. I don't know whether you can appreciate it. Can I have a comment? Yeah. So here are a few lesions in the pons. Is it clear? So this is the plain study. This is the contrast enhanced MRI. Okay, showing many of the lesions enhancing following contrast. And then we have the spine MRI done at the same time. So here is the cervical cord. Showing multiple lesions in the cervical cord here. Okay. And then you have the dorsal spine, showing few lesions in the dorsal cord as well. Okay, there are a few lesions here anterior, which is discontinuous lesions. And post-contrast study, few of them showed enhancement. Very, very tiny enhancement there. Okay, so this is the first MRI of presentation.
Quick question. Do you think that at that time there was already atrophy in the brain?
Well.
Give the question. Give the mic. Give the mic.
Well, I don't think that.
The question was whether there's atrophy present already at that initial presentation.
I don't think there's much atrophy in the presentation, first presentation.
Goes down a little lower.
Temporal regions? I mean, you do wonder, you know, for a 16-year-old, this is for 2007 16-year-old scan?
Yeah, that's right.
Yeah, so I mean, I would agree with you that there's not marked atrophy, although the ventricles may be a little large, and
Yeah.
the temporal sulcus might be a little large, right? So,
For her age.
yeah.
Yeah.
Lactate was elevated. CSF proteins were normal. Oligototal band was present. The NMO result came months later. It was negative. We sent the blood before doing starting the steroid. The VEP was abnormal. It showed anterior visual pathway involvement, and the beta also was abnormal. So we started her. We in Shanganatala have two protocols. For outpatients, we do methylprednisolone 1 gram for 3 to 5 days. But I prefer to give 3 pulses per day. I like to give 1.5 grams because I find in outpatients that group does much better than the group that has returned 1 gram. That's what I do. So the MR findings were suggested of multiple plaques in the supra and infratental white matter, and we had, as I would say, she was doing quite well until May 15th. She was on steroids. On May 31st, she developed again weakness in the right leg. We said that she was already on steroids. She had methylprednisolone only a few weeks ago. So we told her just to rest, not to be under stress, take it a little easy and carry on with her activities as much as she could and not to do too much of exercise. She was managing quite well until the first week of June, when she woke up in the morning with weakness in the left leg, her left arm was unsteady, and her right leg weakness recurred. Everybody was upset, a lot of consultations done. Young girl, going to college, because school had reopened, still hot in Delhi, June. So we've done totally 25 MRIs on this lady, okay, until date. So this is another MRI done on June 7th. It showed new lesions. We told her that she did not require the steroid, it may not work, but it was decided that she takes the steroid, and again another tapering dose of oral steroid was given for her. This was in June. We have this picture now. I have all the reports for anyone who wants. I have this. The June MRI showed a fresh demyelinated lesion in the right cerebral peduncle, and not much of, there was no mention of any atrophy in this scan at that point of time. The MRI of the spine showed enhancing lesions in the spinal cord. So she had new lesions in the brain and in the spinal cord after methylprednisolone was given. So in July, when she had a relapse again, this time with cerebellar signs, double vision, 2 doses of steroid were already finished. There's nothing more to do for the acute treatment. So we went around shopping and we got a consensus that we'll give her immunoglobulin. So we decided to give her 400 milligrams per kg body weight immunoglobulin. Okay? So this was a consensus taken by a group of neurologists. And we told her about taking interferon. First she agreed for 1 injection, then she said she would agree to take 2. Very tough kid. She was supposed to be here today, but she's on treatment today, so probably she'll be on the weekend. She agreed to take beta-4, so she was given immunoglobulin, 15 grams, which is worked out to about 400 grams per kg body weight, daily for 5 days, and started on beta-4 weekly twice. She saw me in August, her double vision was much better, and she continued the interferon twice a week and IVIG therapy every month. She had a pulse of 15 grams. September, she called me and she said that she had hardly had any diplopia, but she developed a bit of stiffness in the legs. I told her that as you get power, new symptoms may occur, and to carry on the same treatment. And she was very happy with the treatment, and everything was going on well. Does anyone use immunoglobulin nowadays for where steroid does not work? Or what would anybody else have done? Steroid
is to attempt to get the inflammation under control early as opposed to waiting a while. So I probably would have used natalizumab tisabri as a first line. I would have used tisabri as a first line drug in her case for a period of time, and then considered what to do after a year or two. She's just got very active disease. I think the likelihood of her responding adequately to one of the first line drugs is... Well, if tisabri was not available, I might have considered monthly cyclophosphamide for a year or two. My point is, I would have used proactive aggressive therapy to try to get this under control. Because I think the likelihood of this level of inflammation will come under control with one of the interferon drugs or with Copaxone is not great. Now, you never know. I don't think anything was done properly here, but it seems as if she needs more than a first-line drug. I don't have a lot of...
Beta-4 only for about 3 months, 2 months, and she's already getting better. With the IVIG Beta-4, she's getting better. Her diplopia is improving. She developed only stiffness in the legs. And if you see, even if I go one more slide, by October her diplopia is gone, her stiffness is gone, and she is back to traveling with her father.
Yeah, I guess I'm responding to the aggressive nature of the MRI lesions and to the frequent relapses in the early course, both of which increase the likelihood that she'll have progressive problems later on. Plus, you're only up to 2007, and she's not here because she's being treated. So, I mean, I think the flavor here is this is aggressive disease.
So, pediatric onset MS. MS is the putative diagnosis. And we have seen multiple early relapses in many of these pediatric presentations. And of course, strictly speaking, one tries to define what is actually a new relapse versus a previous relapse that hadn't got better. And there's a way people have tried to operationalize this over the years, mostly as an attempt to count relapses. If you have one occur on presentation and a month and a half later there's something else new, is that a new relapse or is that the initial relapse that didn't get fully better? Biologically, though, I think this reflects a rather active presentation, and similar to Rick, I would be concerned about this individual and would engage in discussions with him early on about being more rather than less aggressive. As you probably know, there is some data out there that tries to speak to steroid refractory attacks of MS, and that is mostly the Mayo Clinic's experience with respect to plasmapheresis, which is not without its potential burden. But if we're opening the discussion to things that can be done beyond steroids in the acute presentation, then plasmapheresis is another one of those things. Whether there is a subset of patients who have particularly aggressive relapses with more of an antibody contribution has been suggested. Perhaps these are the ones who would respond better to plasmapheresis if they're not responding initially to the steroids.
That's exactly what has happened in her, because as you go on, I'll show you where the steroid makes the disease worse in the same patient. So,
since this is a transcultural discussion, let's see what we would do in Turkey, or I would do, I should say. Well, what we think and what real life is different. Well, for this case, if for the attack treatment, I think I would be quite different from many of the other physicians here. In our center, we use 7 to 10 days of IV methylprednisolone. And we believe that that works better, and we don't use an oral taper. The reason we use 7 to 10 days is because the original studies were done with 3 to 5 days the most, and has been approved as such. But in those initial studies, we believe that mild, moderate, severe, all cases were included. We don't treat mild cases with IV methylprednisolone unless there is a problem with the daily living activities, or it's a severe attack, or it's really disturbs. So the mild attacks are not treated. But when it is moderate to severe attacks, you need more steroids. That's what I believe, by experience, no evidence based, but by experience. So 7 to 10 days. And it has been shown in a few studies, but open studies, that, or comparative studies, let's say, that they work better on MRI at 1 month and also clinical, but not very significantly maybe. But if you take severe cases, that would work better. Well, for this case, I would agree with the meat. I would consider plasma exchange if she would not respond at the 10 days IV methylprednisolone, although that I would have reimbursement problems in my country. Long term, this is a young case, very well brain stem and spinal cord signs, posterior fossa involvement, spinal cord multiple lesions, very frequent attacks. This is an aggressive course. This is going to end up not very nicely. So we would love to use our strongest weapon at the beginning. I would dream of starting, based on my earlier experience, mitochondrial. But now that because of mitochondrial therapy-related leukemia, we cannot use it. I mean, you mention to the patient, they won't accept it, or the parents in this case. Cyclophosphamide, this is my second best, well, only choice at the moment. Monthly IV, and a few maybe weekly and then monthly. But she's 16, and when you mentioned that there might be risks related to the treatment, and she may not be able to get pregnant in the future, well, they won't think that the disease might bring her to the wheelchair. They will say, no, we don't want this treatment. So I would start with betaperone. I wouldn't have not much other choice, and monthly IV methylprednisolone, although that this is not proven to be effective. But Tysabri, I would love to. You wouldn't be able to use it in Turkey unless the patient had been on either Copaxone or interferons for at least 1 year, and it was shown that she is not responsive. I mean, she would not be reimbursed. But in theory, I would love to look to her anti-JC virus antibody status and put her on Tysabri. For her age, that would be my first choice anyway. Although that in heart, I would like to use a more aggressive immunosuppressive therapy. In practice, if I could have reimbursement, I would put her on Tysabri as well.
In October,
anything else from the audience? On the prescription front, if we see, she was getting Bitafron bi-weekly to start with, and then only 2 injections per week. Even that way means the treatment maintenance and preventive treatment is not what is supported by evidence. So even Bitafron, what she was getting lesser dose. We are only bi-weekly to start with, and then twice a week, not alternate days, but it's like 3.5 days in a week. So I don't know any comment on that. That may also be one of the reasons.
We need to.
Yeah, she was a social issue, compliance problem, definitely.
No, but we come to it. They still got water.
Yeah. Everybody can use.
But let me tell you, November 2007, we drove up to Dehradun. We did cycling together. She went back to athletics. She was doing very well. Just with Bitafron twice a week and IVIG. The only thing was the drive was uncomfortable for her and she would be sick while traveling in the car, which was not the case before therapy. She did very well. Clinically, she did very well. She was back, not to full athletics, almost she went back to athletics class. She was doing quite well. And except for this instability while going up the mountains, she would cycle, she would do everything with me. I've done it with her.
Did you repeat the MRI? When
Yes,
you
yes,
did
yes,
well?
I'll show you.
We had an episode, but August onward.
Your double vision was improving. September, she is still better. Then October, she complains of stiffness. I said, no, nothing doing. So I see her in November, we go to Dehradun, we do cycling together. We're quite all right, come back, gone back to athletics. Not full as before, like a normal child. But she's on Bitafron twice a week and IVIG. January, date for MRI. So it comes to me, right? So
What
we
is
have
the
to
dose of Bitafron?
44, that's Bitafron, 44, right? No, not the, what is?
What is she getting?
Bitafron, that is Bitaseron. Yeah, that full, it comes like a pre-filled vial. Pardon? It's pre-filled vial. We know what is coming from.
250 micrograms.
Pardon, it's 50 micrograms?
250.
Yeah, sorry, 250 micrograms.
Alternate day including Sunday.
No, this was given only twice weekly. The girl has done very well. And been pesting again, I'm doing so well, I need to stop the drug. The mother comes and says, I want to know how well my daughter is. So January we do an MRI, and what did we see? More lesions. Then she said, the interferon is not working. I said, no, it's too early. Let us wait and continue the same therapy. So we had this twice weekly interferon, and the 2008 MRI showed new lesions. This is the report that we had. Yeah, 2008. The spine also showed, but this time today, but I have solved it. And here's your gun back, giving it back to his dad. So that happens even in Chennai, right? She was doing very well. She had more lesions, but we did not change the therapy. She was on Bitafron twice a week. Then came the month of May. May is hot time in Delhi. She knows that this is bad time for her. And she wakes me up one day in the morning that she's got tingling and numbness and her hand has become weak. She was still on Bitafron twice a week, but that did her magic, and that from May she could not get back to her class because of this clumsiness in the left hand. Interestingly, she noticed that her car sickness got worse, but the left hand was okay. July went on quite well. This imbalance in the car troubled her a lot, and she got back her double vision for a few days in August. We did not give any steroid, we just told her to continue the same treatment, but her amount of activities have definitely become less compared to before. October when she came, her vision was okay, but the MRI done in 2008 revealed more lesions. Then we discussed, and they said that probably the interferon dose is not enough. You should escalate the therapy. Then she agreed to take one more injection, and we started giving it to her thrice a week. So patient was slightly better on this therapy, and the MRI showed multiple new lesions, this time in the brain. We had new lesions in the spine as well. That was 2008. Patient was doing reasonably well, but activities were down. She was doing quite well, went back to school, she was doing all her work, she could do well. Her performance came down a little bit in school. Instead of first 3 ranks, she was coming from 7th to 10th in 2009 during the final exam. There was a slight fall in school performance which she attributed to missing class during her episodes and difficulty in writing. She's a left-hander. In May 2009, again she woke up with quite severe left lower weakness, and we did an MRI for her. This MRI we had. Quite severe weakness, she had to be carried, she had to be admitted, she got methylprednisolone 750 milligrams per day for 3 days. And we had this MRI in 2009. This patient was doing quite well on therapy, and every time the temperature peaks, we have increase in weakness. Same thing in the city of Chennai. Whenever in the month of May, June, April and May, June, we have a lot of relapses in it. This is, you can be rest assured that some of our patients will come back with an exacerbation of the symptom. We can literally write and say who are the guys who want to come back, either to us or to our colleagues. This 2009? You know, 2009, yeah? May 2000.
So this is the MRI, May 2009, showed a few new lesions. Okay, so she had more periventricular plaques here. There was another new lesion in the right thalamocapsular region. Okay, rest of the plaques were more or less the same. Contrast scan. Most of the enhancing plaques in the previous scan have gone. There are very few, and the new lesions are showing enhancement. Okay, then the spine MRI didn't show much change except for the C5, C6 lesion got a little bigger, but there was no enhancement. So here are all the plaques. This lesion became slightly bigger, but rest of the lesions remain the same. Yeah, that's it.
So for this acute exacerbation, she was given 3 days of methylprednisolone by the family doctor, who now became an expert in giving her methylprednisolone. This was only a telephone conversation. It was too hot. We told her not to travel. She got admitted in a local nursing home. And this time, it was in spite of increasing the beta count to thrice a week in April, May she developed a relapse in spite of increasing in spite of escalating the dose. Then we decided, okay, now what to do? We said we'll give her, in August when she developed more weakness, more tremor in the hand, for which she couldn't go to school for a couple of days, and then she went back to school with somebody with a scribe to help her. She was given pulse steroid. Then we took all the papers and we went to a small MS meeting in Zug where they link up on she's not here. And when Dr. C.S. Agar was there, we discussed this patient and we said that since the interferon is not working, that we could put her on daily glatiramer. So in October 2009, we stopped the interferon and we started on glatiramer. We thought that the drug was not working on her, so we decided to start on glatiramer, hoping that this would do a good job on her. Do you also do this to transfer one to the other? Because we don't have Tysabri at that point of time. We didn't have any Tysabri. The only treatment we have is methylprednisolone, IVIG, and 3 interferons, and glatiramer.
Well, if I wouldn't have any other choice, I would do this. But now, if I believe that the patient is not responding to the first-line therapies, the 4 injectable ones, then I would switch them to either Tysabri or, then immunosuppression I would definitely think in this case. The problem in, let's say in Turkey, it's, not the problem, but what happens is the patients, especially at this age, but any age, MS patient, they would come with their family. generally this is good because the family is supportive and the decision is taken generally together in the family. But sometimes when the parents for these younger patients, they are sometimes worse than the patient, and you have to manage the family before the patient in treatment decisions. But I would go in immunosuppressive treatments. I would do cyclophosphamide in this patient. I believe it may not be able. The question would be, what about fingolimod? Would it be an option? For this patient, I wouldn't think so. I don't think that fingolimod would be more effective than these first-line drugs in this patient, and I would go in an immunosuppressive therapy if I would have the choice of tisaprem.
In November 19, in the month of November, her tremor got better, but this time, last week she developed blurring of vision, and they gave her a pulse of steroid, just one dose they gave her in November. In December, the vision had not improved. She came back down, because last November we had been to Dehradun for cycling. This November she had double vision, blurred vision. She couldn't go to school. She had difficulty. So they put her in and they gave her on 12 December 3 doses of methylprednisolone. And they continued the glytroma stage. The MRI was, we have 9, we don't have 9. The MRI showed more lesions with contrast enhancement in her. We told her that's the only treatment that we had, and we were looking for more treatment. Then came January. On the first week, the beginning of second week, she developed again weakness. Again, the local doctor put her in and gave her steroids, and they changed the medicine back to betafron. They said they didn't have enough luck with glytroma, so they wanted her back on betafron. So the team took a decision and put her back on betafron. That time she needed 2 people support to walk, and she needed help for all her activities. Sometime in March, she had no fresh symptoms, but she was definitely getting better. The cerebellar, the incoordination had got better, but her writing became very slow. And she could not finish her homework. So she needed a scribe, which she had helped earlier, 2 years ago. She got a scribe back to help her. She went back to betafron twice a week, and she started getting pulse steroid. Because at that point, she found that after the intravenous methylprednisolone, she was much better. So now the protocol was back to betafron and monthly pulse of steroid. That was given to her in the month of March and April. She was not normal, but no fresh symptoms. She continued to go to school. She had a scribe to write the exams, and she was on betafron with pulse steroid. As expected, May last year, a year before last, she had again severe pain. She woke up with the heat of Delhi, and she had again worsening of symptoms. She went back to her doctor without telling us anything. She got her methylprednisolone, but this time she said after the steroid, her tremors got worse. So steroid did not help her. She was very clear about it. The doctor was clear about it. So this is what the juice said, that became resistant to therapy, we thought. The scan showed more atrophy and more lesions. By June, her walking had become bad. She could not go to school. There was nothing much we could do, and she went shopping around for other opinions and alternate medicine, which you don't have much details. This was her protocol until September 2010, twice a week methylprednisolone and 1 gram of twice a week betafron and 1 gram of solimodrol once a month. She was quite happy with her progress. Until in October, she noticed that she couldn't see the board properly, and she had an MRI done. We have 2010 MRI? No. It was quite sad to see this girl now had dropped her performance in school. She started failing in her subjects and started complaining that she was getting, by January 2011, that she was getting tired, and this time we noticed that she was very irritable. Her attention span was less. She was forgetting. She was not knowing which exam was what date. This is the first time that this child the mother has told us about significant decline in her higher function. We couldn't do much. They also didn't want to change much. They were just looking around. They were unwilling to change anything. So they said they would carry on this interferon business in January. Then, sometime in January, we had the launch of Tysabri, which was available officially here. So, in February 2011, when she developed tingling and again developed double vision, we did a scan in February 2011, which showed 2 enhancing lesions. Then our eyes woke up, and after the scan, I'll tell you what happened. Scan showed 2 lesions. Tysabri had just come into the market in India, and then we decided that this should have been given to her a long time ago if it was available. I think she was the first Indian patient on Tysabri in February 2011.
Okay, here is the MRI of February 2011. As you can see, there is progression in the atrophy now, and most of the lesions are the same. A few lesions have partially resolved, and there are 2 new lesions which are showing enhancement on contrast. Okay, that is, these 2 lesions are the only ones which are showing enhancement, and a few of them have partly resolved in terms of the enhancement. The cord lesions did not show much change, they were more or less the same, and there was no enhancement in any of the cord lesions.
This is exactly what Arvati was doing. So we gave her Tysabri. What do you think happened? What would you thought you would do well? You thought you were very happy giving us the first person?
Mike, pardon?
1 minute. What would you? Pardon? Pardon?
Couple of comments. There's a very rapidly emerging literature that indicates that new MRI lesions that occur while on beta interferon, and it doesn't matter which product, indicate a very poor prognosis for patients who remain on beta interferon. It's been shown for beta 1A, both forms of beta 1A, beta 1B, and this has been shown by measuring the MRI anywhere from 6 months after the onset of therapy all the way up to 2 years. So there's an increasing evidence base to suggest that when the patient has new lesions on one of the interferons, that it's a good idea to get them off interferon. Now, if they have antibodies to interferon, there's some rationale to switch to Copaxone. But if they don't, switching from one first line, I agree with Axel, switching from one first line to another first line is probably not going to be too helpful. The head-to-head studies comparing either beta-seron or Reviv to Copaxone show essentially the same effectiveness. You can't tell, you can't tell any difference between the treatment arms in randomized direct comparison studies. So it seems unlikely to me that someone like this, if she were antibody negative or antibodies to interferon, would respond very well to Copaxone. When we switch patients from the first-line drugs to Tysabri because of breakthrough disease, they are generally very happy patients. You see them 3 months after or 6 months later, they generally tell you this drug's working much better. In this case, it's a little hard to know because she has such severe disease and it's been going on so long that it's hard to predict, but it would not surprise me if she's been doing better in the last year.
Just a question to, there is no difference. But is this only for the first 3 months or 6 months, or does it hold true even beyond?
Well, the head-to-head trials are 2-year studies. So taking patients who are treatment naive and randomizing to either beta-furon or Copaxone, or in a different study to Rebif or Copaxone, you couldn't tell a difference in the treatment effect over 2 years. As a matter of fact, you surprisingly couldn't see a difference on the MRI over 2 years. Now, one of the studies, the Beyond study, tested the regular dose of beta-furon versus twice the regular dose, and there was no dose benefit. And I've recently reviewed all of the interferon studies and wrote a chapter on this. I think that the dose effect of interferons, this is my personal opinion, and I'm perfectly willing to admit I could be wrong, but my personal opinion is that this dose effect of the interferons has been exaggerated, largely through marketing efforts. So the fact that she was only on beta-furon twice a week rather than 2 times, 3 times, or every other day, I don't think that makes too much difference. When you look at the original beta-furon study, there was a difference at 50 micrograms every other day versus 250. But the difference was only really seen on the relapse rate. There wasn't much difference on the MRI effect or any other outcome measure. But that led to the concept that there is a very prominent dose effect. With Rebif, 22 versus 44, 3 times a week, very hard to see differences in the outcome of 22 versus 44. There were a couple of measures where there was a difference. The drug was marketed at the higher dose largely to distinguish it from beta-1A IM, which is given once a week, and the argument was that's underdose. So my own personal opinion is that the mistake I see in practice all the time in patients that are referred to me is they break through Avonex, and so they go to Rebif 22 3 times a week. They continue to have disease activity, so they go up to 44 3 times a week. So my only point in bringing this up is if a patient goes on any of the interferon products, which is very appropriate, and it was appropriate in this case, and there is then breakthrough disease evident on the MRI after 6 months even, I don't think it's a good idea to escalate the interferon dose, because as you see, this is generally what happens. So I think switching this person to escalating the therapy. Cyclophosphamide monthly is perfectly fine. Tysabri, if it's available, is fine. Fingolimod would not be unreasonable, although I would share the concerns.
So what about worsening of symptoms while putting the patient on glatiramer? The patient significantly came down. Then while putting back on the Vitafron, it came back. Do you think it is disease natural activity, or do you think that the glatiramer did not work in this patient? Because while on the interferon, she did well for some time. Then we gave it a break. Then you...
I think it's very difficult to make those kinds of causal relationships because the frequency of relapse or even MRI activity varies in individual patients over time. So if you look at one 6-month period or one 12-month period and compare it to the next, it's somewhat variable within the patient. So it's a little hard to know whether or not she responded less well to Copaxone. I don't think I would be able to say. But in general, I have not seen patients who do poorly, very poorly on Copaxone and then do great on interferon or the vice versa. I just haven't seen it. I've seen a lot of patients referred in who have been switched between the first-line therapies, and they generally continue to be active when you watch them for a period of time. There was a recent study I just saw in multiple sclerosis from the Prosperini group in Italy that randomized patients with breakthrough disease to switch between the first-line therapies or to escalate to natalizumab. And they monitored these patients, so it was randomized. a pretty well-matched, sizable group. And they saw both on clinical and MRI measures that the patients did better on the escalation therapy. So it's really sad that this wasn't available to you, because she's gone for 4 years with a lot of brain injury.
This was our first patient of Tysabri. We gave her the first dose in February. This was the Feb MRI. Before we gave her the first dose, there were 2 new lesions, and we had active trigger with the infusion of Tysabri. Then we said that probably we don't know how to infuse Tysabri, in spite of going to the literature which we carried out. And after that, she was sent home the next day. The March MRI showed there's 1 more new plaque on the right side of the brain. The others are the same. April end was her 3rd dose. This time she was significantly better, so she willingly came for her injection. She was very good. She was able to walk. She had much improvement in her hand, eye. She got back to a lot of activities, and she was very happy with the drug. In May, she was, since she had a lot of shivering occurring 3 times, then they advised us to use steroid and an Avil injection. Avil is an antihistaminic, so that no reaction would occur after the infusion. So this was done in May. She was so well, she was so happy. She went back to normal. We sent her for an adventure camp. I showed a short video of her sometime about her rock climbing and rafting. She had left-hand tremor, but she could do so much what she could do 2 years ago while on the drug. She was so happy. She came back, and at the end of June she had a Tysabri with the pre-medication. July she noticed that her balance was worse, and the hand tremors came back, and the tiredness worsened. She was not as active as what she was. So we found that she said that the June dose did not do her good. That was her interpretation. And she also said the same thing happened with steroids. Before I would take methylprednisolone, I would jump around. Then as you keep giving me the drug, it doesn't work. And the same thing is happening with your drug doctor. Exactly what the child told me. So we said, no, don't worry, this is a new drug. Probably this time it will do you better. So we gave it to her, but by August, she was unable to write. She developed severe cerebellar signs, severe nystagmus like what she had earlier 2-3 years ago. And the August MRI showed 3 new plaques with 1 enhancing lesion. You have August? I have the reports here. The August MRI scan read there were appearance of 3 new demyelinated lesions, and in spite of having so much of Tysabri, we had an active lesion in the brain and worsening of the patient while on Tysabri.
Do you have antibody to Tysabri? Do you have levels of antibody?